Okay, so we ended the previous lecture here with the cubital fossa. So let's take another look at that just as a quick review. Here you can see the outline a little bit better, the borders rather. So from epicondyle to epicondyle we have the superior border. You can see a little better here how the brachioradialis makes up this lateral border and how the pronator teres is going to make up this medial border. You also get a better view of the brachial artery and the median nerve as they travel into the cubital fossa. And just to be complete here, make sure you notice that there is a bin of body bits here and that there's also a hand here. The muscles that act on the elbow are going to be, the main elbow flexor is the biceps brachii. And you can see how it is a two-joint muscle. It does cross the shoulder joint here. It crosses the elbow joint here, and it also crosses the proximal radial ulnar joint here. So it does cross three joints, and that's important to note because as we start to stretch these muscles, we have to be able to stretch them along all three joints. So right now you need to understand where this muscle lies because in Therex we're going to talk about how to stretch these muscles, and it's a little bit more complicated when we're talking about muscles that cross multiple joints. We also have the the brachialis. This is the deeper elbow flexor, lies underneath the biceps, and you can see how it is a one joint muscle. It only crosses the elbow joint. The brachioradialis is the final flexor of the elbow. It's a much smaller muscle, and you can see how it starts to become a thin tendon as it moves across the forearm. This is the tendon that we are trying to strike when we're trying to find the C6 DTR. And here they are together. Of course, you can't see the biceps or the brachialis rather, because it is underneath the biceps. But these are the anterior muscles of the elbow joint, and with the exception of the brachioradialis, the others are innervated by the musculocutaneous nerve, and the brachioradialis is innervated by the radial nerve. On the posterior side, we have the extensors, the main one being the triceps. Now, the triceps is also a two-joint muscle. It will cross the shoulder here as it moves down across the elbow joint here. So you can see the muscle, and this is the tendon that we're trying to strike for the C7 DTR. There's also a smaller muscle, the anconeus, which assists with elbow extension. Not a very big muscle, but you can see how it does cross the elbow joint and it does help with elbow extension. It's a posterior muscle, so it's going to be innervated by the radial nerve. The supinator is the main muscle for supination of the forearm, and it is going to be on the lateral aspect of the forearm, and you can see how it crosses over onto the radius, and these muscles, this muscle has to attach on the radius since that's the only bone that moves. The insertion is found on the radius. The biceps is also a supinator, and we can't forget that. It's a very strong supinator because it does cross that proximal radial ulnar joint. Here's the pronator teres. It is the main pronator of the forearm. Starts on the medial side, it runs across and inserts on the radius as well because it is a pronator. Radius is the only bone that moves. It has to insert on the radius. Here you can see the cadaver view of the pronator teres. The pronator quadratus is also a pronator. It's a very small, flat muscle. It's essentially a little square, and it's very deep to most of the other structures that are found here. So looking at this picture, if you see this on a muscle chart, make sure that you are able to quickly distinguish which bone you're going to put with the insertion. You can see it through here, a very small muscle. Here's a better view. Once several other structures are removed that we'll talk about momentarily, you can see how deep it is and why it's so hard to palpate, and why we only stick to palpation at the pronator teres. This one would be way too deep to palpate. It'd be very difficult to feel anything. The innervation for these muscles really are the same. We've talked about these with the brachial plexus. The radial nerve travels on the posterior part of the arm and innervates all the muscles that are found on the posterior aspect. The musculocutaneous innervates the muscles that are above the elbow joint. The median and the ulnar nerve pick up and innervate the muscles that move below the elbow. Now the ulnar nerve has a little section that is very superficial and exposed. It travels through the cubital tunnel, and it's at this point where if you have any excessive pressure or a hard strike on it, you get that zinging sensation down the arm, the funny bone. So when you strike the ulnar nerve, you feel those sensations, either the tingling or the pain, traveling down the medial aspect of the arm into the little finger, because that's where the sensory pattern for this nerve is down the medial aspect. That's the dermatome. But this is your funny bone. All right, now let's talk about the wrist and the hand. So here you see an x-ray of the different carpals as they would look positioned in an actual person. Let's look at an illustration of these for a moment. The carpals play an important role in fine motor control of the hand. There are many muscles that control finger motions, and they are extrinsic to the hand. In other words, they originate in the forearm. They have to cross the wrist to get to the finger joints. So these carpal bones help position the wrist for optimal length tension relationship of these muscles. And again, that's very important because these muscles are controlling very fine motor skills. So the length of these muscles has to be optimal for all this to occur. And these carpal bones help position the wrist so that the muscles are at the appropriate length tension relationship to perform these functions. So it's best if we have a way of thinking of how to order all these carpal bones. And they are divided into two rows, a proximal row down here and a distal row here. For me, it's easier to think of the person in the anatomic position as we start to name these bones. So what we see here is a left hand, the anterior view of the left hand. So if we start at the proximal row and we move thumb side to little finger side, lateral to medial, we have the scaphoid here, the lunate, the triquetrum, and the pisiform. And of course, the triquetrum is the bone that you learned to palpate and to mark for the axis of the goniometer for wrist flexion and extension. So again, on the proximal row, the scaphoid, the lunate, the triquetrum, the pisiform. If we move back to the lateral side and start on the distal row, we have the trapezium, the trapezoid, the capitate, the hamate. And those are the carpal bones of the wrist. Together, we have two wrists to discuss here. The proximal row, as they come in contact with the radius, forms the radiocarpal joint, and the two rows, as they come in contact with each other, is the mid-carpal joint. As we mentioned in the previous lecture, the ulna doesn't articulate with the carpals. There's a little gap here, but there are some structures that help connect these two bones, the ulna with the carpals. Here we see the ulnocarpal ligaments. They connect the ulna to the carpal bones. And we've already mentioned the triangular fibrocartilage complex. So let's revisit this for just a moment. This is the disc that fills in the gap between the ulna and the carpal bones. The triangular fibrocartilage, in addition to filling that role, filling that gap, also has other roles. First, they provide a continuous gliding surface across the forearm bones for carpal movement. So since there is no articulation, this becomes the articulation, as again most discs do that. The second is that they cushion the forces that are transmitted through the carpals to the ulna. It connects the ulna to the carpals. It allows the carpal bones allows the pronation. It assists with the pronation of the distal radio-ulnar joint, and it adds support to keep the radius and the ulna together during pronation and supination. The radiocarpal joint is the distal end of the radius with the scaphoid, the lunate, and the triquetrum bones. The articular disc helps fill in the remaining gap here, but the radiocarpal joint is usually thought of these three bones and the radius. The primary stability for this joint is the dorsal radiocarpal ligament and the volar or the palmar radiocarpal ligament. These ligaments help stabilize the radius with the carpals. The dorsal radiocarpal ligament becomes tight in full flexion, and this palmar or volar radiocarpal ligament is much stronger and thicker, and it becomes tight with full wrist extension. Additionally, we have these smaller ligaments here that help stabilize the radius and the ulna with the wrist. We have the ulnar collateral ligaments here and the radial collateral ligament here. Here's a cadaver of the wrist joint. You'll notice the carpal bones here, and the hand is down here to give you a little reference. This wrist is in extension, but you'll see how there are ligaments on either end here to keep these carpal bones with the bigger forearm bones, and how these carpal bones are really just in contact with each other. The two rows form the mid-carpal joint, and while there are several ligaments that help keep these together, we're going to keep it very simple and just refer to them as a group: the palmar intercarpal ligaments and the dorsal intercarpal ligaments. These ligaments help keep these bones together during movement. Everything is wrapped up in the extensor and the flexor retinaculum. You see it here, and it travels across both sides of the wrist, the anterior and the posterior side, and we're going to talk about that momentarily. Here you get to see a cadaver view of the same structure. So together, all these joints help move the forearm, the wrist, and the hand. They work together, again, because of all the fine motor control that is required at the upper extremity. These joints all have to work together to provide that fine motor control. When we look at the structure of the forearm, the wrist, and the hand together, we get what is the power line of the wrist, the most stable part of the wrist. And that happens to fall through the third metacarpal to the capitate, over the lunate, and to the radius. In fact, when boxers are taught to punch, this is really the point of contact for any punch, because it is the most stable part of the hand, and it's referred to as the power line of the wrist. So these joints that we've talked about are synovial joints. The radiocarpal joint, the midcarpal joints are synovial joints. They have ligaments, capsules, and they allow we're working together, they allow sagittal plane movements of the wrist in flexion and extension, frontal plane movements with ulnar and radial deviation, and circumduction where we cross several planes at the wrist. Onto the hand. The hand serves some important purposes as well. It is a motor organ, so we do lots of manipulations of the environment with the hand. Eating, writing are all some examples. It's a sensory organ. It can very easily detect changes in temperature or texture, and it provides us with the most important aspect of function for our upper extremities, which is all the fine motor control or the primitive movements for manipulating the environment. The joints of the hand then are going to be the most distal row of the carpals with the metacarpals, which together form the carpometacarpal joint. There are 5 of them, and as with the foot, they are numbered 1 through 5, starting with the thumb and ending with the small finger. Of course, the thumb has a unique carpometacarpal joint. It is a saddle joint which allows opposition of the forearm, or opposition of the thumb. The metacarpophalangeal joints are the metacarpals as they articulate with the proximal phalanges. These are the metacarpophalangeal joints, or the MCPs. And then as we move down distally on the hand, we start to form the IP joints, the interphalangeal joints. So those are the articulations between the phalanges of the hand. And again, as with the foot, the thumb is only going to have one interphalangeal joint here, and the remaining fingers are going to have a proximal interphalangeal joint and a distal interphalangeal joint. The anterior portion of this fascial tissue, the flexor retinaculum, forms the roof of the carpal tunnel. It helps to hold the flexor tendons in proper place as they travel underneath the structure, making their way into the fingers. It increases the mechanical advantage of the flexors, and it stabilizes the wrist. So this structure here helps to stabilize the wrist, as we mentioned previously, but in addition to that, it prevents the tendons that run underneath here from what's called bowstringing. It keeps them so that they don't just very loosely move as they cross the wrist, and that's important for length-tension relationship. The flexor muscles that run underneath here are the flexor digitorum profundus and the flexor digitorum superficialis. In addition to that, we see the median nerve that comes underneath the flexor retinaculum. Here's another view of the same structure with the muscles and the nerve in place. So you'll see how these tendons run underneath here next to the nerve, which gives it, much like the subacromial space, is a very tight-fitting area. And with excessive compression, we can get inflammation of either the tendons as they make their way under here or the median nerve. And this is, when the median nerve is involved here, is what is referred to as carpal tunnel syndrome. Here you get to see the distribution pattern of the median nerve. So anytime anyone is complaining of carpal tunnel, it has to fit the sensory or the dermatome distribution of this nerve, which, as we know in class, is going to affect the thumb and the first finger, parts of the middle finger potentially. But any symptoms that are traveling on this side of the hand cannot be due to median nerve issues. The dorsal retinaculum is the posterior side of this fascial tissue. This is also a thick band of fibrous tissue. This also helps to secure the extensor tendons as they cross underneath the structure over the wrist as they make their way down into the fingers. And much as with the other side, this helps keep the length tension of these muscles appropriate. It prevents bowstringing of these tendons so they're stuck firmly under here and they don't have a chance to be too loose under there. One of the important features of the posterior part of the hand is the extensor hood or the extensor expansion. This is on the distal ends of the metacarpals and the proximal phalanges. The extensor digitorum tendon begins to flatten out and forms an extensor expansion which wraps around the dorsum and the sides of the metacarpals and the proximal phalanges, as you see here. And here's the hood portion of it. It flattens out and then expands across the sides of the metacarpals and the proximal phalanges. So what's the important aspect of this? Why is this important? So it helps to keep the finger joints moving together, and that's very important for function. I'll give you some of the lists of what it can do, and then we'll play with it a little bit in class. So the function is we have flexion. When we have flexion of the distal interphalangeal joint, it results in flexion of the proximal interphalangeal joint. When there's extension of the proximal interphalangeal joint, that results in extension of the distal interphalangeal joint. When there is flexion of the MCPs, this can occur concurrently with extension of the pips and the dips. So again, we're going to talk about that a little bit more in class because it's a little hard to convey that in a recording. But just know for the moment that the extensor hood or the extensor expansion is a way to keep the joints moving together, which is important for function of the hand, normal function of the hand. When the extensor hood is suffering from some sort of pathology, typically from rheumatoid arthritis, we start to see this at the joints, and as you might imagine, this is not a very functional hand. There's going to be some severe limitations with what can happen here. So the extensor hood helps to keep the joints from this. There are some muscles that we need to talk about here, and there are the muscles of the thenar eminence. So this is the thumb side of the hand, the padded side, on the palmar aspect. So there are some muscles that form that little padded area known as the thenar eminence. So the first is the abductor pollicis brevis, seen here, the flexor pollicis brevis, and the opponens pollicis, moving from most superficial to deep. These are the muscles that make up the thenar eminence. We also have a hypothenar eminence, which is the padded side on the little finger side of the hand. The muscles that make this up is the abductor digiti minimi, the flexor digiti minimi, and the opponens digiti minimi, again moving from superficial to deep. These are the muscles that make up the hypothenar eminence. In the mid-palmar region, we have this list here that we find moving through this part of the hand. But more importantly, what I want you to notice here is this palmar aponeurosis. It's a long fibrous expansion that covers the palmar aspect of the hand. This aponeurosis helps form some of the insertions or the attachment points for the intrinsic muscles of the hand. Sometimes this can become tightened to the point where the hand starts to become a little deformed, and there's a technique that releases this tissue so that it doesn't compromise hand function. But really all I wanted to point out here was that there is a palmar aponeurosis that fans across the palmar aspect of the hand. As we saw in the foot, we have arches that help stabilize the foot. We have arches that we can find in the hand as well. The three arches are the proximal transverse arch, the distal transverse arch, and the longitudinal arch. In the hand, these are going to mostly provide the mobility necessary for function, but can provide some stability. The proximal transverse arch travels across the distal row of the carpals, with the keystone being the capitate. This forms the posterior border of the carpal tunnel and is the most rigid of the arches of the hand. The distal transverse arch travels across the metacarpal phalangeal joints, with the keystone being the third metacarpal. This is a mobile arch, and the second and third metacarpals keep the hand very stable. The fourth and the fifth metacarpal heads are the more mobile part of this arch. As you make a very tight fist, you can see how the fourth and the fifth metacarpals have a little bit more movement than the second and third. So this provides the movement necessary for a tight grip. And the longitudinal arch, excuse me, travels along the third finger, moves across the third metacarpal down through the capitate. This arch helps deepen the hand. So as you flex your fingers, you can see how your hand can cup, and that's what this arch is there to help. It provides some concavity to the hand. Another region that we need to talk about is the anatomical snuff box. This is the depression of the dorsum of the first metacarpal. The image here that you see is these two give you an idea of what we're actually looking at, and it's this hollowed region right through here. The muscles that help form this area are the tendons of the extensor pollicis longus on the most medial border, the tendon of the extensor pollicis brevis, the most lateral border, and the tendon of the abductor pollicis longus. These three muscles give you that anatomical snuff box, as it's referred to. This, what you're seeing here, is called Guillaume's canal. It's on the medial border of the hand. It's a canal that's formed by the pisicohamate ligament, so it's a ligament between the pisiform and this hook of the hamate. The canal here is there so that the ulnar nerve can travel underneath, and this keeps the ulnar nerve secure under that between these two bones. This could potentially be a site of compression of the ulnar nerve if you have a lot of weight bearing on the most medial portion of the hand, right through the carpal bones here. You can start to get some compression there. When the radial nerve is involved and there's injury to it, since it innervates the muscles that are on the posterior part of the arm, anything that extends the wrist is going to be involved, any of the muscles that extend the wrist. So with a radial nerve injury, you typically see this, what's called a wrist drop, because the muscles are unable to support the wrist in extension. With ulnar nerve injury, you get what is referred to as the benediction hand or the bishop's hand deformity. This ulnar nerve is going to involve, obviously, the muscles that are on the ulnar portion of the hand. When there is no innervation, or when there is limited innervation, then you see this deformity because the muscles cannot support this portion of the hand. The only other nerve that travels into the hand is the median nerve, and when you have injury to the median nerve, you get what is referred to as ape hand deformity. I'm sorry I couldn't find an image for that, but we'll cover that in class.